Welcome to our weekly Zoom news conference. I'm Sandy Close, Director of Ethnic Media Services. Today marks the 50th in our weekly Zoom briefings, which we began March 27th, 2020, to track the impact of COVID-19 on our communities. We thank Blue Shield of California Foundation for its continuing support of this initiative. Today, we zero in once again on the virus and the race to vaccinate enough people to reach herd immunity before variants gain ground that may be immune to existing vaccines. To address today's topic, we're honored to have two returning speakers, Dr. NIRAV SHAH, Adjunct Professor of Medicine at Stanford University, and Dr. Danielle Turner-Liberis, founding member of the Latino Coalition Against COVID-19. We welcome today two new speakers, Dr. Dolly Phan, UC Davis Health Science Clinical Professor, and Dr. Kim Rhodes, Associate Professor of Epidemiology and Biostatistics at UCSF School of Medicine. We'll send extended bios and contact information about our speakers, along with a video of the conference, to all participants this afternoon. We ask reporters to enter questions in the chat box. After each speaker, our moderator will select several questions, and we will have a final Q&A at the end of the hour, time permitting. Our thanks to our interpreters, Oscar Arteta and Jackie No, for providing simultaneous interpreting in Spanish and Korean, and to our conference coordinators, Pilar Marrero, Sunita Sarabji, Tanu Henry, and Anthony Advincula. I'm turning the conference now to today's moderator, Sunita Sarabji.
Good morning, everyone. Let's just get right to it. Dr. NIRAV SHAH, the senior scholar at Stanford University, will provide an overview of the issue, the race to get enough people vaccinated before the mutant variant B117, the dominant variant at this point, takes over. Dr. Shah, welcome.
Thank you, Sunita. It's an honor to be back with this group. I'm excited to talk to you all a little bit about what's been going on lately. Today is an important milestone in America. Today, we will collectively administer our 100 millionth COVID-19 vaccine. That means over 75 million Americans have gotten at least one dose. And so while we have a lot to be happy about with this important milestone, we cannot start to celebrate just yet. The story of virus variants is a story of evolution and natural selection. So what happens is the more virus particles there are, the more chances that just by chance alone, a single virus particle may be a little different than the rest of them. Many of the variants, in fact, all of the major ones that we've seen, start by this, where there's a lot of virus going around, many people infected. One or more virus particles is all you need to have a slight change. Maybe the spike protein changes just a little, and it can attach to cells a little better than all the other virus particles. That's evolution and then natural selection. That one spreads a little faster because the spike protein is different, it can attach differently. And that leads to that becoming the dominant strain. Now, what happens simultaneously is we're trying to treat these people, right? We're trying to keep people safe. And to the extent that there's pressures now that we're not going to spread as fast, the virus particles are getting attacked, the ones that have selective advantages relative to other virus particles are going to spread much faster. So it's a race of how fast we get people protected, meaning fully vaccinated, versus the level of disease in a community and how much we see transmission going on. So this is where we are in America today and in the rest of the world. And the CDC, the World Health Organization, UK, all of us are now starting to understand how these variants of interest are spreading. There's actually four if you count the UK. The UK calls the very first variants under investigation. Variants under investigation are those that we think it's different than the rest of the COVID vaccine strains that we've seen, but we don't know anything about it yet. After variants of investigation, there's three real levels that we should be focusing on. And those are variants of interest, variants of concern, and variants of high consequence. These designations matter. Let's start with the variants of interest. What is a variant of interest? A variant of interest has caused a cluster of infections in America or other countries, and it seems to be driving a surge in cases. Its genetic sequence has some changes that suggest it might be more contagious, or that it can escape from immunity, or the kind of immunity you get from vaccination. Treatments and tests may not work as well against that variant. And today, the CDC is watching three variants of interest. The most common one that you've heard about is the P2 variant. We are trying to get away from referring to variants by country or location where they were first widely broadcast. So I'm not going to say that the P2 variant was detected in Brazil, because it doesn't mean that the first case was actually from Brazil. And for the P2 variant, we still don't know the actual transmissibility and lethality. We don't know how vaccine recipients are fully neutralized against or not. So it's still early stage, but it's lower risk in terms of how we think about the stages of concern. So variants of interest are then followed by variants of concern. A variant of concern has been proven to be more contagious and or to cause more severe disease. So that means that therapies that are being developed are less effective against this specific strain. And vaccines may also be a little less effective against this strain. People who have had one strain of COVID may be potentially reinfected with a new strain that is a variant of concern. And today, there are 5 of these variants of concern being tracked by the CDC. The one that you've heard the most about is the B117 strain. And we know that from published research to date, early studies show that it transmits from one person to the next about 50% faster compared to some of the original strains. And we also know that that strain can also lead to increased mortality, with up to 60 to 70% increased death from this relative to the old strain in a paper published in March 15th in Nature. The Pfizer and Moderna vaccine antibody response is a little bit less when you have the B11 strain compared to prior strains, but it's still susceptible overall to the vaccine, as well as still susceptible to the Oxford and AstraZeneca vaccines and the Novavax vaccine. So good news, B117 seems to be a little more virulent, faster to spread, and a little more lethal. On the other hand, our vaccines to date all cover it. Other strains like that in the same variants of concern category include the B1351, which also has increased transmission and a reduced effectiveness of the Pfizer vaccine, up to 8 or 9-fold, reduced effectiveness of the Moderna vaccine, possibly by about 6-fold, as well as the AZ vaccine is less effective as well, perhaps on the order of magnitude of about 10% effective. The Novavax early studies suggest it's about 55% effective, and the J&J vaccine is also less than 60% effective against this strain. The P1 variant has some conflicting studies about how much more resistant there is, but again, susceptible to Pfizer vaccine, and we don't yet know for the P1 variant how transmissible it is and how lethal it is relative to the prior strains. And then there are 2 strains, the B1427 and B1429, which also have increased transmissibility and decrease in terms of the titers of antibodies you get from the Moderna and Pfizer vaccine as well. So those are the variants of concern. The next level that is something called a variant of high consequence. And variants of high consequence cause more severe disease and more hospitalizations and have been shown to defeat medical countermeasures. They've proven to, for example, like vaccines, antiviral drugs, monoclonal antibodies. To date, there are no variants that meet this definition as of a variant of high consequences. This is important. To the extent that we win the race, we will win the race by making sure that we stick to the easier to attack, the ones that our vaccines are still protecting variants, and we have to get people vaccinated as quick as possible, as broadly as possible. We're also in the process of now looking at variant vaccines. J&J and others are testing various different combinations of how, now that the spike protein has changed, is there a variant we can use in our vaccine that will better attack that variant in the spike protein? There's also talk about multivalent vaccines. Just like with the flu vaccine every year, the flu vaccine is actually a combination of several different types of vaccine against several different specific strains of the flu. 3 strains more. That's the kind of approach they're going to be taking now with COVID vaccines as well. I'll stop there and look forward to the questions.
Thank you so much, Dr. Shah. I think the first question that I have is, what does herd immunity actually look like, and when do we see ourselves getting to that point?
That's a great question. So the question about herd immunity is an important one. When we reach herd immunity, that means likely 60 to 70% or more of the population is resistant to the strains of virus going around. That means it bounces off of them. It doesn't allow, it doesn't, if you're protected, you're not going to be a host for potential genetic variants to grow in. And it's an important level to reach. However, there's going to be several factors here. First is, we've seen already over a dozen states are relaxing restrictions. So for example, if you're not mandated to wear a mask, it's no surprise that a lot of people in a given state are not wearing masks. That's a problem, because what happens is those are the public health measures proven to work against spread. As we have more people infected, we have more chance of variants. So there's a race going on right now in terms of how many people we can get a shot in the arm of a vaccine to reach that 60, 70 or more percentage. Remember, none of the vaccines are perfect. So what we're doing by getting up to that level will ultimately then protect the vulnerable. The good news on one hand is that many of the older adults in America are protected. One population that's been ignored and hasn't been reached effectively are the vulnerable, homebound elderly, the frail elderly who haven't been able to get out to vaccine appointments as well, or haven't been able to go to hospitals or other places, or even sign up for vaccines. As of 2 weeks ago, that rate of vaccination among the homebound elderly was only 20%. They're very vulnerable. And so we need this level of herd immunity to protect those who are vulnerable, who either are not protected by the vaccine for one or more immune reasons, are homebound elderly, haven't gotten vaccines, and other vulnerable populations. With now new testing happening in children, the hope is that we can get high schoolers vaccinated as well. And by the fall, we should be getting closer to that, if not there. And depends again on how many people actually roll up their sleeves for the shot. And we're hoping that as many as possible will do so.
Absolutely. I have one more question, but there are a number of questions in the chat. Is this a vaccine that we're going to have to get again next year, given that we're now reconfiguring the vaccines?
Yeah, as we said, it's a race of the mutant viruses versus the vaccines. And to date, none of the mutants have escaped fully the major vaccines that are going around. So our hope is that with minor modifications, we can get a continued evolution of the vaccines to match the evolution of the viruses. Realistically, it wouldn't be surprising if we had to get every year, just like you get a flu shot maybe you'll get your COVID shot as well. The reality is that until the whole earth is vaccinated and we reach herd immunity, there will be pockets of people who haven't been vaccinated where the vaccine will survive. And all it takes, we know how fast this spreads, is for one of those people to get on a plane and expose other people who aren't part of the 20-30% that aren't vaccinated, perhaps. You have 70% for another strain and another little infection cycle to start again. So this is a race for the world. We know the virus doesn't respect any borders. And so we should be as broad as possible in our thinking about getting the vaccine to everyone across the world.
Absolutely. There's a question from Pilar Marrero. Pilar?
Okay, just a minute. Thank you so much, Doctor. So I know there's a third surge or fourth, I've lost track, surge around the world in many places. Many places in Europe are shutting down again. Right now in my country of birth, Venezuela, there's a massive surge. My own brother is infected. His wife is infected. My best friend is infected. His wife is infected. There is no vaccine in the horizon for many of these countries. How can that affect all of us? I mean, we know the United States has been doing okay, considering, right, all the problems, etc. But in many other countries, and I know that's why, one of the reasons why President Biden decided to give some of the surplus AstraZeneca vaccine to Mexico. But how can that affect all of us and the pandemic worldwide?
Yeah, that's a great question. So this is something that it's very easy to forget about our neighbors. You won't get back to life as normal. You won't be able to get on a plane and hop anywhere in the world unless the whole world is back to protected. We absolutely must do more to protect all of our neighbors. This virus does not respect borders. We must also take that view and be much more proactive. There are worldwide efforts to do this. The race is on. How fast can we do this before some bad variant shows up that is actually a variant of high consequence that then leads to us, even though we got the first dose of the vaccine, the second dose, we're no longer protected against that new variant of high consequence. That is a very real possibility. It's of course incumbent in our own interests to make sure this happens, but it is one world. You're right.
Henrietta Burrows has a very interesting question. Henrietta?
Unmute. Oh, there we are. Thanks so much, Sunita. There seems to be a very high level of intelligence going on in viruses, Dr. Shah, where they infect their hosts and kill the host, but not too many hosts, because that would interfere with their survival. So has there been an attempt, and I'm sure there must have been, to find out where the seat of this intelligence is in viruses and to reprogram the viruses themselves? Because we always seem to be in a reactive mode where we're creating something that will defend us against them. But what about trying to interfere with the actual intelligence of the virus itself?
The viruses are a very interesting group of particles. They live somewhere between alive and dead, according to most definition of what is alive and what is dead. You could freeze these viruses for years, unthaw them, and they're still virulent. So we don't know how to perhaps call them alive or dead. The reality is the evolutionary aspects of it is very well understood. So in terms of a higher intelligence versus just how they're reacting to their microenvironment and how chance alone is leading to genetic mutations, it's the latter. It's chance alone driving these things. When you have 1 million particles, chance alone, in terms of how they reproduce to the next 10 million or 100 million, chance alone from radiation, from whatever it might be, will lead to small changes. The vast majority of mutations probably die away. But all you need is a few mutations that are in the spike protein, for example, that make it latch on a little better, that give it a competitive advantage relative to other viral particles that lead to that evolution that we're seeing. So while we think it's intelligent, it's scary how smart this virus is and how it's moving from one place to the other. Sadly, it's just the nature of how we're moving, the nature of how we're wearing masks or not, the nature of our policies in terms of restaurant openings and large gatherings that lead to this kind of intelligence. And it's really a reflection of our bureaucracies and our policies.
Interesting. Dr. Shah, you've answered this question to some extent, but Mira Kaimal has a question that I think bears a little more explanation. Mira? I can ask. Oh,
Yes.
there you go.
Hi. Thanks, Sunita. So Dr. Shah, I guess, yes, you did answer, maybe the first half of my question. So I guess I'm trying to understand, will we need a new generation of vaccines before the current vaccine rollout is complete? And when do you have an idea when boosters might be introduced?
Yeah, so as you know, I'm an optimist. I like to hope that we are getting ahead of us of the various mutants. The reality is they're continuing to surprise us every month with something new. I would imagine that we will have boosters shots by the fall that have some differences from what we're currently rolling out. How widespread they are is anyone's guess right now. I think it would be a guessing game, and I can't make that up. But what's important is that we all get that first shot. Let's get in line, make sure the vulnerable, make sure the elderly, make sure everyone gets a shot wherever you are. Call 5 people and see if they haven't gotten it and make sure that they're in line to get it. That's going to make us collectively win. And then also, as we heard from the other speaker, we need to get this done internationally. There's no question we're going to need evolution of our vaccines. That's already happening. How fast it's urgently needed, how fast we need something that has totally broken free is anyone's guess.
Dr. Shah, thank you so much for joining us today. We very much appreciate that. We move on next. We're going to go a little bit out of order to Dr. Dolly Fan of UC Davis. Dr. Fan will talk about the Johnson & Johnson vaccine and how this might be a game changer in terms of our ability to administer in time. Dr. Fan, welcome.
Thank you for having me. Before I go to my talk, I want to just make a couple comments about the questions asked in the past. I mean, first of all, I'm not an immunologist. I don't pretend to be an expert in that regard. But my understanding of herd immunity in general is, if you look at the community, when the viral particles start to come down, that's where you got herd immunity. So tomorrow, if the virus particles is less concentrated, less than absolute numbers than today, that's herd immunity reached. So think about a clogged kitchen drain. I mean, you can stop the faucet, you can start to drain it, or you can boil the water that's retaining in the sink. Whichever way you can do it, as long as the water level comes down, and you get it. The second comment is about the virus. Again, not a virologist, but based on what I read from the way the vaccines develop and the way the immune system interact with the virus, and I don't think this virus is any different than any other viruses that we interact with. And actually, very fortunately, it actually interacts with our immune system very predictively, based on what my reading is. And then you look at the vaccine, especially the mRNA vaccine. It is extraordinarily fortunate that the timing was not 5 years ago. So the first mRNA vaccine was not 2020, it was actually 2017. So the technology couldn't have come any faster. So I mean, that's really not the part of my talk. When I sort of engineered my talk a little bit so that when I play my talk, I want to share my screen so that I don't repeat myself too much. Just bear me with a second with me. I didn't go, so that's not good. Can you see my screen or no?
Yes.
Can you see my screen? Oh, okay.
Yes.
Good morning. My name is Dolly Fan. I'm a health science clinical professor at the University of California, Davis. I want to thank Ethnic Media Services for giving me the opportunity to talk about Johnson & Johnson COVID vaccine and its impact. I have no conflict of interest on this topic. The information provided on this slide is largely from the CDC's website. I put the link of the CDC website on the bottom of the slide for the audience. From the published clinical trial data, the J&J vaccine can provide 67% efficacy preventing moderate to severe COVID-19 infection. This is from the 14 days and the 28 days analysis. Moreover, the J&J vaccine at 14 days prevents 77% severe COVID-19 infection. At 28 days, it prevents 85% of severe COVID-19 infection. And at 49 days, it prevents 100% of severe COVID-19 infection. Moreover, at 28 days, the J&J vaccine reduces hospitalization by 93% and death by 75%. Uniquely, at 10 weeks, the J&J vaccine reduces asymptomatic infection by 75%. Importantly, the J&J vaccine has very low severe adverse event rate at 0.4%. This is similar to plain saline injection. There are a lot of numbers comparing games in the media lately. Here, I want to caution people, try not to compare apples and oranges. These 3 trials were done at different times and different places. These trials were up against different viral mutants. And up to date, there are no clinical trials compare these vaccines in the same study. What we do know about these COVID vaccines are that all 3 vaccines are very effective against symptomatic COVID-19 infection, 65 to 95%. All these COVID-19 vaccines reduce COVID-19 hospitalization by over 89%. Most importantly, no vaccinated patients died from COVID-19 in clinical trials. I know this is a big statement, so I provided the information source about these statements. Again, no vaccinated patient died from COVID-19 in clinical trials. So how does the J&J vaccine fit in the overall blueprint against COVID-19 pandemic? Let's take a quick look at the characteristics of the J&J vaccine. It is a one-dose only vaccine. It requires only regular refrigerator storage for 3 months, so it is easy to transport. The processed vaccine, you do not need to dilute or reconstitute the stock. So where does the J&J vaccine best fit? First, the J&J vaccine fits perfectly for mobile and pop-up clinics. It is easy to set up. It is also convenient for newly established vaccine administration sites where you may not have established storages. It is also good for rural areas where -80 freezer may not be as readily available as big cities. Secondly, the J&J vaccine may be a better option for people who want to get fully vaccinated quickly with 1 dose only. It may be an option for people who don't want to or cannot return for a second dose. For example, be afraid of needles or just don't have transport. The J&J vaccine may also be a good option for people who are highly mobile or for people who are homebound. Where do we stand now? President Joe Biden announced on March 11th that the goal for the administration is to make all adults in the US eligible for vaccination by May 1st. Pfizer-BioNTech, Moderna, and J&J vaccines are the 3 players on our side. With them, the vaccine production is favorable. Now, vaccine distribution has become the bottleneck. The current situation calls everybody to do his or her parts. Doctors, nurses, pharmacists, industry players, political leaders, educators, and volunteers. It is truly a community effort. Lastly, I want to share my personal experience in the past 7 weeks. I've been volunteering at the California North State University community vaccination sites since the end of January. It is truly a joint effort of the community and the medical institution. Yesterday, I found 3 teachers that are inoculated by me for both the first and the second dose of the Pfizer-BioNTech vaccine. It gave me a great personal satisfaction for putting 3 fellow Americans into the fully vaccinated population. Thank you very much. Questions?
Thank you, Dr. Fan. I have a couple of questions and then we'll get to the ones in the chat. First of all, there's some confusion about the types of documents you need to have when you show up to get your vaccination. Could you explain that a little bit? And do you have to reside in the county where you're going to get your vaccination, or can you just go wherever one is available?
Wow, I'm not the expert for registration. So at least our place, we follow strictly of the California tiered system. So the vaccines, you cannot purchase the vaccine. It's distributed by the government. So we follow their rules, and then the regulation comes with the rules. So right now, first tiers are the elderly and the medical caregivers. And then in addition, we inoculate teachers, so that that's the next tier, so that we can get kids back to school. So you show up, I think there's a registration process. I think in the California, there's I think it's My Turn. There's a website, I don't really remember the website.
myturn.ca.gov. Yes.
And COVID19.ca.gov. I think there are 2 places that you can register to find if your turn is up or how you can register. Just that you can't, it's not a commercial product. So it's strictly regulated. My understanding is that.
I have a question for both Dr. Shah and Dr. Fan. I'm going to personalize this for just a bit. I'm a 60-year-old woman, almost 60-year-old woman with a past history of epilepsy, and yet I am nowhere in the queue. Does the CDC need to reconsider who it is prioritizing? I'll let you answer that question first, Dr. Fan, and then Dr. Shah, if you could as well, that would be terrific.
I think it's dependent on the availability and the means of administration. So I don't have these numbers in my hand, so I wouldn't even start to comment on whether the CDC policy should be changed or not. I wonder what Dr. Shah thinks.
Yeah, I think the CDC has been very responsive recently in updating its guidance, in providing transparent thinking about what it's doing, why it's doing it, how it's doing it, to really try to get vaccines to everyone. You know, the president has said that by May, everyone who wants a vaccine should be getting a vaccine, which, considering the time lag from when the virus first occurred to now, is quite fast. There are ways to get vaccines. There are people who stand in line in Las Vegas, where they have lots of extra vaccines at the end of every day at 1,000 different sites. And I know young people who have gotten vaccines because they don't want to waste any doses. And so there are ways, if you're interested, yes, it's not convenient, to potentially get a vaccine, even though you may not be in that spot in line.
Thank you. Dr. Fan, there is a question from Jaya Padmanabhan who asks, do we know if any of these vaccines have side effects?
Think about it. The vaccine has been 100 million in America. So if you talk to the vaccine, so the straight answer to that question is no, there is no serious side effect. The reason, there's multi-tiered reasons. If you talk to the experts, which I'm not one of them, that there wouldn't be, the preliminary feedback would not be mature unless you got 3 million doses. But 3 million, we're at 100 million in America. I mean, if you look at Israel, greater than half, better part of the country is vaccinated. So if they were a serious fact, you would have seen it. We're talking about short term, less than a year. Was there anything long term? We don't know. We won't know until we have 5 years We won't know until we have 10 years. Those things you can't speed up, you can't guess. So far, so good.
Fantastic. Manny Otico has a question. Manny. Yeah. So Manny asks, what can we do to speed up the bottleneck, Dr. Pan?
One at a time, I guess. So everybody needs to do their share. For example, there's a lot of administrative issues. For example, today is the 19th. On the 21st, we have a joint effort to go to an underserved area, sign up 1,500 people in the underserved area to administer the vaccines. We mobilized 250 volunteers, but at the last minute, it conflict with the county's regulation, so the event was postponed. So I think it's less medical at this point. It's more management, but those are the things I wasn't taught in medical school, and I know a good manager can beat 100 doctors at this step.
Dr. Fan, thank you so much for joining us. We very much appreciate you being on this briefing. We next welcome Dr. Daniel Turner-Lloveras, a familiar face to people who have been on these previous briefings. Dr. Turner-Lloveras. Are you there?
Sorry, I think I was on mute. Can you hear me?
Yes,
okay?
There you are. Welcome.
I just wanted to thank you for the warm welcome. I just wanted to echo Dr. Dali Fan's words, in that none of us were trained for, maybe some of us were trained for pandemics, some epidemiologists, some infectious disease specialists, but many of us, were not trained for the scenarios that we've seen in the surges that, we've all sort of gone through caring for our patients. I don't want to repeat many of the excellent points made by our previous speakers, but one thing I did want to bring to everyone's attention is, the question of when will we reach herd immunity? And that's an important question, because oftentimes the question that's being asked is, when is normal going to return? When is the path to normalcy going to be closer to us, reaching that final destination where we can walk around with masks off? I don't think anyone with confidence can say when that would happen, but we do know that herd immunity most likely will be reached once we meet the threshold of the number of people that are vaccinated. And so getting people vaccinated is of the utmost importance. And I think everybody would agree on that. What is preventing this from happening? I think initially the problem was that the rollout began under President Trump, who decided that it should be up to the states, up to the counties, sort of a broken, disconnected rollout. If we had been more unified, I think that would have helped with a lot of the messaging and a lot of the communication with different groups, especially Blacks and Latinos, since now each state, each counties are coming up with their own methods for delivering culturally sensitive health information. Some are doing it excellently, some not so great, and it would be wonderful, if everyone could sort of share resources in their strategies in reaching out to these vulnerable populations, which is one of the reasons sort of behind the Latino Coalition Against COVID-19 is to come together so that we can share the resources, and especially the ones that we're finding work better than others. Another issue I wanted to address is the importance of the digital divide and digital exclusion and digital literacy. So overnight, every industry went from person to person to virtual. We saw how our educational system adapted. I think one of the reasons why it didn't do so well was because teachers weren't taught how to teach virtually. This is not something that comes natural to many people. If you have an experience within computers, then it's a lot easier, but without that, some teachers didn't know how. And I think those students definitely did not benefit from going virtual. Another group that did not benefit from going virtual were the underserved, which predominantly were in Black and Latino neighborhoods. First, because many of them didn't have internet access. You have news articles covering students that were doing homework in McDonald's parking lots in order to get internet access. And that's just something that really needs to be addressed. Internet access, I think is a civil rights issue at this point, because we know of all of the resources that are being provided to people are now online. If you want, disability, unemployment, these are online forms. If you want to sign up for food deliveries from food banks, online. Signing up for vaccines is an online process. And it's really the minority communities that are being left out in the telehealth boom and the race to sign up for vaccines. And unless we do something about it, they will continue to be left out, and it will continue to contribute to the unequitable distribution of COVID-19 vaccines. So in a recent report done this year, 22 million American seniors do not have broadband internet access at home. That's 42% of the nation's 65 and over population. This is the group that we really need to get vaccinated. This is the group that's at highest risk of complications, yet this is the same group that's not connected to all of the resources that are available. So we know internet access is a critical link to social contacts, health information, financial management, government assistance. Before the pandemic, 57% of Latino families said they owned a desktop computer compared to 82% of whites. And as the pandemic surged, nearly 40% of Latinos did not have broadband internet access at home. This is a major barrier to education, healthcare access, and which is one of the reasons why we started the Digital Compañero program. So this is a program led by bilingual volunteers who reach out by telephone to Latinos, and this would be either elderly who are not comfortable or not able to use internet or the computer, or anyone, including immigrants who don't have the digital literacy to get online and to sign up for these resources. We're also implementing a WhatsApp channel, since we know that's a commonly used communication platform among the Latino population, and they can sign up via sending a text message as well. So one component would be to get them online, teach them the skills, because not only would this be helping them sign up for the vaccines, but we know that economically, Latinos have been the group almost most affected by the pandemic. And we know that if you have these digital literacy, if you know how to use the internet and computer skills, your likelihood of finding a job that will benefit you and your family is much, much higher. So that's one component, is to teach them the skills and get their digital literacy level up to a point to where not only can they sign up for vaccines, but also would broaden the options for finding a job during and after the pandemic. Second component would be to address the vaccine hesitancy, which has been confusing over the past several months. Many of us were not clear whether it was vaccine hesitancy or barriers to access to the vaccines that was leading to this inequitable distribution, but it's probably a combination. And so one component would be healthcare workers communicating with these groups and just listening, talking to them, asking them what are their concerns. And oftentimes we found that answering just basic questions about the vaccine and disproving, debunking myths that are spread on social media, many of them then convert to wanting to get the vaccine. Ideally, this is done in a virtual environment, like in a virtual town hall, but this is another option for those who are having difficulty. Ideally, we would be able to teach them the skills so that they could join in on a virtual town hall. But until then, we're also going to be trying to reach out via telephone. And there's a lot of groups that are doing this in person by, there's a great group in Philadelphia. I think they're with the Black Coalition Against COVID-19, who are bringing in community members to trusted places like churches, and they're getting huge numbers signed up and vaccinated. And that's another strategy. Some people don't feel comfortable going into a person-to-person location, and that's where the digital compañero program, I think, would really help out with these groups. But we really need to look at this as a civil rights issue, and I think if we do, then we can start to make the changes that would allow for this barrier to be overcome and to increase the number of people getting vaccinated and get us closer to herd immunity.
Dr. Turner-Llevarez, thank you so much for your comments. Last week, I was drilling down on data in Sacramento County, and the number of Latinx people that had received the vaccination at that point were roughly 12, I believe it was 12.4%. And I wonder if that's of concern to you, and what needs to happen here?
I would just echo what I was talking about. Is we have to look at what are the barriers, and I think most of the barriers are access barriers, which are either they don't know where to sign up. Signing up also is a problem. So even if you are computer, you have a digital literacy level that's high enough to where you would be able to get online and sign up via an online form, people are having difficulty finding which website. Difficult, and there was a few people on social media that were taking screenshots of farm workers. They were assisting farm workers to sign up for vaccines, and then when they entered the information, it said that the vaccine was not available, although it was stated that it was available to farm workers. So there are definitely glitches in the system, and I think everybody has sort of experienced this. I know I signed up my mother for the vaccine. Initially, she was hesitant, but I know for a fact she would not be able to do it on her own. I had difficulty because it was busy and I had to refresh, and then at some point it closed down. I had to re-log in. So these are just, I think a lot of people are going to need hand-holding, virtual hand-holding, not necessarily in person, in order to get us to the numbers that we need. Also, the low numbers are a reflection of the inequities that have been long-standing in the Latino population. So I don't want it to seem as if this program of overcoming the digital divide is going to be the answer to all of the problems faced in Latino communities. This is one piece. What we really will need to do is, what is the root cause of this disparity between Latinos, Blacks, and other populations in getting vaccinated? It's longstanding health inequities. And so we need to start creating and investing in the programs that are addressing these issues. Also, in the incarcerated population, we need to invest in programs that will prevent them from being reincarcerated once released. We also need to make sure that we're vaccinating those in detention centers because they also deserve a vaccine. And an outbreak in a small, crowded place is probably the worst place for a surge to happen. And so we should also be trying to get these areas vaccinated so that we prevent any potential surges that may be coming. I know. So yesterday, there's a group of epidemiologists, the COVID-19, the KidRap viewpoint. This is a group out of the University of Minnesota who are very worried about the B117 variant. And they're predicting a surge at the end of April. And so they are saying, and I agree with them, that our time window, is small for where the number we want to get as many people vaccinated as fast as possible so that it prevents the surge. Because the surge can't happen if everybody is vaccinated and the virus is unable to spread and infect and seriously make a high number of people seriously ill in a short period of time. So all of these things are really need to be at the forefront of our work and our efforts moving forward.
There are a couple of questions about how to be able to access the digital compañeros program and the WhatsApp group that you mentioned. Could you just give us links to those?
Sure, I can put those in the chat.
Okay, perfect.
Me saying the long, but it's lcac19.org is the homepage. But I'll put in the link, the direct link to the program and the phone number.
Dr. Turner-Lloveras, thank you so much for joining us yet again. We welcome your remarks. Next up is Dr. Kim Rhodes from UCSF. She is Sorry about that. Dr. Rhodes is up next from UCSF. She has developed pop-up clinics, test sites in East Oakland. Dr. Rhodes, welcome. I believe Dr. Rhodes is not yet on the call. So
with this, Sunita, this is an opportunity for us to deal with more Q&A with the speakers who are on, because it's such a great conversation. I'm sorry something must have happened with Dr. Rhodes, but we'll have her on a future call. But let's go to more questions.
Absolutely. So Ritu Jha had a question previously. Ritu, could you please ask your question?
Yeah, hi. Can you hear me?
Yes.
Yeah. My question is regarding J&J research ongoing still, I understand. And when to expect the vaccine in the market. And secondly, I have talked to a few people, they are not very much comfortable taking J&J vaccination. So any feedback on that?
The right answer in terms of the vaccine is take the vaccine you're offered. You want to be protected. All of them confer protection, perhaps at varying levels, but remember, they were tested in very different areas, as Dr. Fan mentioned. So the right answer is roll up your arm, get whatever vaccine is offered, because it's much better than getting COVID.
Think about when you take an exam, right? I'm going to tell you what score you're going to get. Either you get a 0 or you get a 90 versus a 95. So which one? A 0, get beat up by mom and dad, or 90 or 95 is A or A minus. Think about that.
Okay, thank you so much.
And Mira Kaimal has a follow-up question on the AstraZeneca vaccine. Mira.
Yeah. Yes, about the AstraZeneca. In Europe, a number of countries have paused the vaccine because of concerns about blood clotting. So is this a decision based on science, or is this a political move?
Shihan.
So the AZ vaccine is actually safe. As you may have seen, that many countries have now reversed their initial blockage. It was the stopping was based on politics, not based on the science. The rate of blood clots that was seen was very small. In fact, it was less than what we expected in a normal population. So please do report that the AZ vaccine is safe. It is now being rolled out in those countries that had temporarily paused. And there's no evidence to suggest that it is unsafe.
Sunita, I see that we're joined by Dr. Rhodes. I wanted to make sure you knew and that we can welcome Dr. Rhodes for our last speaker.
Dr. Rhodes, thank you so much for joining us. We welcome you. Please begin.
Hi, thank you for having me, and I'm sorry, apologize about my late arrival. I I did try to start my video, but it is telling, I'm getting a message that I cannot start my video for some reason.
So just having you speak, Dr. Rhodes, is fine.
Okay, great. Oh, and
There you go.
And technology comes through at the last minute.
Welcome.
Thank you so much. I think the only thing that I was wanting to share about is our efforts in engaging the African American community around COVID-19 awareness, kind of participation in testing, and now moving into vaccination efforts using a community-based participatory model. And I don't call it research because we really put research on the back burner. We think if we provide service that sometimes research will emerge from that, but that the priority right now in terms of addressing this pandemic is actually service, and service in the name of public health. Umoja Health is a collaboration of about 20 to 30 Black serving organizations that came together under the umbrella of Umoja, which means unity in Swahili. It was a branch of the United in Health efforts that you may have heard about that have taken place in the Mission District. That's really where it started, with community-led COVID-19 test and response, or test to care model, where we test, bring testing into the community, engage the community through canvassing by community members and community activists and community partners. And then when folks test positive, we provide a wraparound service, which is called the Community Wellness Team, where folks get case management call every day. We ask them what their potential needs are in terms of PPE, cleaning supplies, and groceries. We provide that for them so that they can stay home and break the chains of transmission. So Umoja Health emerged out of the grandchild, I would say, of the efforts in the mission. After the results from the mission showed that those who could shelter in place were the ones who were not getting infected versus the day laborers, there was an effort to look at the same kind of issues in the African American community. So under the auspices of the Chancellor's COVID Equity Task Force, I led an effort in Bayview, Hunters Point, and Sunnydale. We did a mass testing site there in both of those locations. And actually what we really learned from that, which was much different than what was seen in the mission, was that the African American community had a lower rate of infection. What was interesting to me was that there was a lot of press around the Bayview effort until we tested 400 African American residents and had 0 positives, and suddenly nobody wanted to cover the story. I find that very interesting because it suggests that the narrative needs to be one of inequity, lack, deficits, instead of one that focuses on positive outliers and asks the question, well, why were there 0 out of 400 positives in a time when we had a 2% infection rate in San Francisco? So we went on from there and learned a lot of lessons because the community developed a very rapid trust in us. I was very surprised by this. And called out to us when they found out that one community member had tested positive, and they knew that that person touched a number of households. So they called us and they said, can you come back out and provide more testing? And when we did so, we did it in neighborhood on the streets. And we saw neighbors going to neighbors' doors, knocking on doors and telling them to come out and get tested. And what we recognized from that is that a mass testing site was not going to work for the African American community, but something more intimate would. And so Umoja, which happens in Oakland, in Deep East Oakland is where we started. Now we're across Alameda County with our vaccines, is based on a pop-up model. We mobilize with local folks who do door-to-door, hand-to-hand, face-to-face, peer-to-peer, answering questions about COVID. And as we moved into vaccination phase, the Alameda County Public Health Department recognized that as a major asset because we were able to reach with our testing resources about 57% of those resources went to African American people. 60% of those African American participants were first-time testers, had never been engaged with COVID before. And so they knew that when vaccines came around that we would be able to reach people that they couldn't. And so now we are actually an official vaccine provider as a community-based organization in Alameda County. That's our short story.
That is a terrific story. Yeah, Dr. Rhodes, I have been reading a lot about, your challenge to the myth of Black vaccine hesitancy. I wonder if you could talk a little bit about that, because that is a prevailing sort of narrative in media reports.
Yeah, absolutely. And I want to refer people to our website, which is at www.unitedinhealthoakland.org. And the reason that I'm suggesting that folks take a look there is because we post all of our meetings. Umoja Health meets on a weekly basis to share information, get people prepared for what's coming down the pike so that no one is surprised. And in one of our meetings, we had one of our collaborators from Axville Gospel describe the scene at Axville Gospel Church when FEMA came with a pop-up. And it's a very organic, she's just sharing, we said, who has had a pop-up, please share with us, that Black people were running for the vaccine, running.
Wow.
Literally running. And I think it's important for that story to get told, because I feel that vaccine hesitancy is a pretext for explaining away the inequities that we're inevitably going to see when we are sort of done and have our big thousands of numbers of vaccines that have been passed out. We'll say that, well, the Black people are just hesitant. And when we don't use that terminology within Umoja Health.
Absolutely. I'll ask you the same question that I asked Dr. Turner-Uveras. Looking at Sacramento County data just a week ago, fewer than 13% of the Black population in Sacramento County had been vaccinated. Do those numbers alarm you?
Well, they're alarming just in the truth about what we need to do to get out of this pandemic. So I'm looking for power before I lose power. So they're alarming for just for the public health purposes alone. But what I would predict is that the way that the vaccines are being distributed have a significant impact on who is getting vaccinated. I think a reporter asked me recently, do you think that hesitancy is the reason? And I had to think about it, because I'm certainly not saying that Black people do not face a history in this country of untrustworthy behavior by public health institutions and by academic healthcare delivery systems and community healthcare delivery systems. So there is an issue of responding appropriately to untrustworthy behavior, which is to say, okay, I'm not sure I trust that. But what I think I've come to realize in how we do our pop-up work is that the trust piece comes in, or the hesitancy piece comes in about who's offering this to me. Because the question is, what is your motive in offering this to me, right? There may be some technical questions about the vaccine itself. Is it going to alter my DNA? Will I become infertile? But I think the biggest hurdle is who's offering this. I heard in a San Francisco Department of Public Health meeting when just as Pfizer and Moderna were getting emergency use authorization, and the question was about the AstraZeneca trial. And what the community partner said was, funny, you weren't fast to try to get me tested or get me access to testing, but you're fast to get me this vaccine. And so here's the dilemma. If Black people are never first, and in our healthcare system, Black people are never first, let's be clear, what's wrong in this scenario where you want me to be first? That's what we're up against.
Mm-hmm. Right, absolutely. I'll ask this question for both Dr. Rhodes and Dr. Turner-Uveras, if you're still on the call. Does it have to be members of the community administering the vaccine for people to have trust in getting the vaccine? Does it simply come down to that?
In our scenario, I would say no. I do have one Umoja Health partner collaborator who's been with me since Bayview, who would not accept the vaccine unless I administered it. And so I did, and that's the only vaccine that I've actually given. But the people who work on our site, and we really noticed an increase in white people volunteering for Umoja at our last pop-up. We had 25 brand new volunteers. And I have to say, the folks who have been with it the whole time were shocked and afraid of what our site would look like and whether or not we would still be conveying the same message. But the reality is, it's the philosophy that we live by. What is our goal? Our goal is to make sure that our resources get to the African-American community. We will literally serve whoever shows up, but we know what our goal is, and we know when we've had a successful day. And so we do a big speech before we get started, especially when we have new volunteers, to make sure that they understand what our goal is and who is being prioritized at our site in terms of how they are interacted with, how they are cared for, what they are offered. And so the reality about this pandemic is the only way out of it is together. That is the only way out of this pandemic. So I don't think that the vaccines have to be offered by people who are of a certain color or look a particular way, but they have to be carrying the mission with them if they're going to be on our site. And I think that matters to the folks who come to our sites because they've been invited by Umoja to be with us. So
fantastic. Dr. Turner-Uveras, any thoughts?
Well, first, I'd like to thank Dr. Rhodes for her work. So I'm originally born in East Oakland, California, and I'm still a Raiders fan and A's fan, but that's offline. But thank you for what you're doing because, you know, there's definitely a need in East Oakland. And, you know, I just see the same needs here in LA, in East LA, South Central LA, and every urban city, you know, every urban setting in every city across the country. I think what Dr. Rhodes has shown us is that we need to reach out. Having an online sign-up form for a vaccine is not reaching out. That is, you know, a resource that is out of reach for most people. And so, once again, I'll bring up the Digital Compañero program, but in addition to the Digital Compañero program, you know, which will be overcoming the barriers, the digital barriers to getting online and signing up for resources, signing up for food stamps, signing up for all of these things that would benefit them and their health, we need to be doing in-person reaching out. We need to be reaching out by whatever means that they are available. So, you know, if it's telephone, it's telephone. If it's knocking on the door, it's knocking on the door. In a pandemic, it's not as easy to knock on the door. And it's going to be hard to knock on everyone's door because, you know, there isn't a Dr. Rhodes in every neighborhood, unfortunately. And so that's where, you know, the calling and basically calling and talking to them and then doing the things on the computer for them, you know, can often have sometimes the same effect. Although for some, the trust comes from seeing them and for some, seeing is believing. And we know that racial concordance between patients and physicians is a real thing, and that it does improve outcomes and improve the likelihood of compliance with recommendations. And so I would say in some component, there is a benefit to having the provider of the same, you know, race or ethnicity as the patient. And in the Latino population, it's a language issue also, to be able to speak Spanish. Although my mom's a translator, so I love them. I don't use them, but I love translators because, you know, that's what my mom used to do. Translators can definitely also help overcome those barriers.
Fantastic. We're going to end this call. There are already requests in the chat to reach out and do individual interviews with each of you. So I think your remarks were most welcome and very informative. Sandy, closing remarks?
I just echo everything you said. I want to follow up with each of the speakers. We could have gone on. I just thank them very much. I do think a very clear takeaway for me as somebody who's in her late 70s is thinking about the frail at-home seniors who, as our first speakers indicated, have the lowest vaccination rates and are very much at risk. I was truly unaware of that. So much new knowledge gained. Thank you very, very much.
There's 19 million adults over the age of 65 that live alone.
Wow.
And so for Umoja, we think of ourselves as gap fillers. So we're functioning in a number of different counties. In San Francisco, we're popping up actually in Potrero Hill, which is the one neighborhood in District 10 that has not gotten any vaccination. But what we're going to be doing also is getting a little mobile van, and we're starting to work with folks in Hayward right now to figure out how we're going to get door-to-door vaccinations to the seniors who are isolated and can't get out.
That's amazing.
Thank you.
Thank you all for the work that you do. Dr. Dolly Fan, you are also a volunteer vaccinator. All three of you, and Dr. Shah, who had to leave, also volunteer vaccinated. So tremendous work, and thank you all so much for the work that you do to keep our communities safe.